All right, good afternoon, everyone. Thank you so much for joining us today. Our session is titled Using Hybrid Cardiac Rehabilitation to Expand System Capacity and Patient-Centeredness. We have a very great session planned for you today. Given the strong interest in this topic area, so in hybrid cardiac rehab, we have decided to do things a little bit differently than we have for the past modules. And what we've done differently this time is we have opened it up to the Take Heart Learning community members as well. So we recognize today we've got kind of two groups of folks on the line. If you are joining us from the Take Heart Learning community, welcome. We are so glad that you're here with us today. You'll hear a little bit about how we've done things in the past, but then we'll jump right back into the content for today. If you're joining us as a partner hospital, I do want to really congratulate you for making it to this 10th and final module of the Take Heart training series. We know it's been a really long haul for you guys, having started before the pandemic for many of you and working through the pandemic. So just really want to congratulate you for making it to this point. This is not our final session also, so just a heads up, there will be some invites coming out for an additional meeting or two, as we look to reflect on everything that's occurred so far and maybe get some feedback from you guys. But welcome both to the learning community members and to the Take Heart partner hospitals. On the next slide, just as a reminder for folks, all of the materials that are included in the Take Heart training content do come directly from the Million Hearts AACVPR Cardiac Rehab Change Package. There's a link that's included here, as it's been included in all of our training materials, and you can find that change package within the Take Heart Resource Center directly. The way our setup is for these training components is we do have an expert-led training session today. That's what you're attending right now. For those who are partner hospitals, we will continue to follow up with your peer action groups so that you can do some of the peer-to-peer sharing, some of the troubleshooting together, and you'll also receive a how-to implementation guide on how to do these activities. Please know that at any time you can reach out to your coaches as well for any feedback, any thoughts, and again, be on the lookout for at least one more meeting after your peer action groups with us as well. For those of you who are partner hospitals, also, we do have the opportunity for you to claim the CEU credits, so there'll be a follow-up email related to that if you are interested in claiming the CEUs. And then last housekeeping item before I move it over to Steve Hines. For those who are new to this session, please know that we really do like an active dialogue throughout the chat feature. So we do encourage everyone to go ahead and use the chat feature. If you are new to the system in any way, you can access it through, what's shown up here on the screen. We do ask that you set your comments in the to field to everyone so that we can all see your comments and be able to chat with one another. Again, we have been building up to this session for quite a while and are really excited for the speakers we have today and to be covering some of this content. And with that, I will pass it over to Steve Hines. Steve.
All right, thanks very much. And thanks to all of you that answered a couple of questions that we asked in the registration about your use of hybrid cardiac rehab. You'll see on the screen the responses that we got from that. And about almost half of you have never offered hybrid, or perhaps you only used it for a short period of time during the height of the pandemic. But we're really pleased to see that about a third of the people on the call this afternoon are likely to be actively exploring or are already using hybrid cardiac rehab. And we want to encourage you to share your insights as Stephen and Ann talk today, and by all means participate in the chat. Just to kind of give you another sense for the reasons why people are either using or not using hybrid. You see that the programs that are using it really view it as the best option for some eligible patients. On the other hand, participants that aren't using hybrid cardiac rehab, issues associated with resources and reimbursement are major issues, and we'll be touching on those during the presentation today. So I do want to now introduce our panelists. We have specific learning goals that you can see here, and this is what we want to accomplish So we look forward to covering those materials today. And they will be covered by Stephen Katayan, who's the Director for Preventative Cardiology at Henry Ford Hospital in Michigan, and Ann Gavitt-Ott, who's a manager of cardiopulmonary rehab and diabetes services at Northwest Community Hospital in Illinois. So we're going to cover briefly what hybrid cardiac rehab is, address the reasons why every cardiac rehab program should understand the hybrid option. And then we want to talk about how you can evaluate whether that would be something that you should be more seriously exploring to meet the needs of your patients. So having said that, let me turn it over now to Stephen Katayan.
Thanks, Steve, and to Take Heart for the opportunity to present. And to the group, I will say we have a lot of information to cover. I would encourage you to use the manual that accompanies this, as well as future projects that may come down the pathway for us to, grow on this journey as we move towards, an alternate delivery or another delivery model for cardiac rehabilitation. And it's important, I'm going to spend a couple slides on terms and definitions, and it's important we cover this because it really will set the foundation for not only what we cover today, but as you read the literature going forward and you talk to other people going forward, that we try to get on the same page. Facility-based cardiac rehabilitation is what we think of day in and day out, early outpatient, standard, traditional cardiac rehabilitation. A new term for some of you, when we deliver facility-based cardiac rehabilitation, it's always face-to-face, right? It's synchronized with the patient at the same time. Well, there is another form of synchronized cardiac rehabilitation, and that would be for me to talk to you using a real-time audiovisual connection, your cell phone, WebEx, however you want to do it, and me observing you, let's say, exercising at home, or observe our patients while exercising at home. And then a third term that we have to start to think about would be asynchronous cardiac rehabilitation activities. And this means the patient is doing the activity potentially independent of cardiac rehabilitation staff. They're reviewing materials that were provided to them by email. They're reading online, educational materials. They're exercising on their own. They're loading their information, through a platform, or they may be talking to you about disease management, on a Friday afternoon, and they exercised on Thursday. So those are three key terms that we want to keep in mind. Next slide, thank you. But what we're building towards is this fourth term of hybrid cardiac rehabilitation, and I'd like you to think of it just as the name implies, that there's some facility-based visits. Could be 1, could be 10, could be 12. And those are intermixed based upon clinical need with both synchronized sessions, observing the patient while they're exercising at home with an audiovisual connection, and asynchronized connections as well, where again, the patient may be loading something up to a platform, totally independent, exercising on their own, totally independent of, let's say, potentially a cardiac rehabilitation staff. Right now, we're avoiding the words remote, virtual, home-based, because we're feeling that this may be adding to the confusion a little bit, because these words really haven't been anchored across the profession. So we're going to try and stick with today, and hopefully we get there, facility-based, synchronous, asynchronous, and a combination of those, hybrid. And these definitions come out of the think tank that Million Hearts conducted in the fall of last year. Next slide. So what is hybrid cardiac rehabilitation in terms of what is it and what is it not? So it isn't just exercise only. We tell all of our patients to go home and exercise without any direct supervision. We want you to exercise on your own at home. But without all of that means what is it? It contains all of the elements of cardiac rehabilitation. It's not just exercise only, it's not just education only, but it's the assessments, it's the counseling, it's the risk factor management, it's the behavioral support, it's the activity counseling, And it could be facility-based visits, it could be synchronized visits, it could be asynchronized visits. But it really is this multi-dimensional effort that we're delivering to the patient. Next slide. So still hammering our way on this same concept, but we're doing it now with a little bit more graphic. To the far left, you can see facility-based cardiac rehabilitation. Just as I said before, the black-bodied person, the blue-bodied person, they're in the same area, and one is supervising the other. Hybrid is a combination now of facility-based, again, the two people in the same area, and synchronized real-time audiovisual connection. Again, I'm seeing Anne, let's say, exercising at home, and at alternative times, could be synchronized, could be not. When the patient isn't, is or isn't exercising, we might be connecting with the patient in terms of educational materials, getting material from their devices, them reviewing materials, etc. So it's really a hybrid of the two. Next slide. So this is the Henry Ford model, and it's not the only model that's out there. We're wide open to other models, and it's pretty self-explanatory. We encourage the patients in our hybrid program to, just like everybody else, get to 36 total sessions. We want to shoot for that goal, and it could be through 2 to 3 sessions per week. We try to get in at least 1, but up to maybe 12 facility-based visits. That would mean 24 to 35 of their visits are synchronized audio-visual connections. And we may have asynchronous visits where we follow up with them at other time period about other information. If they're in facility, then we're doing ECG for some of those visits, not all, maybe just the first 3 or 6. Blood glucose monitoring if they need it, blood pressure monitoring if they need it. If they're home, we give them a pulse ox, device that's for their fingers, so we can get their heart rates while they're exercising at home. We have internet available patient education. We give you a resource, a link for that. I think many of you may have seen it before. Home-based cardiac rehab would get you to the webpage, and then it's just audio PDFs after that. And like everybody in facility-based programs, baseline 30, 60, 90-day ITPs are completed. Discharge reporting goes out, just standard like we would do for a full facility-based program. Next slide. So let's pause for a sec, and I did all the talking, so I get to be quiet and then develop the scope of how you got to where you're at today with your program. And you might be on mute.
How's that? Thank you, Stephen. And thank you all for attending today. I appreciate the opportunity to share our experience. And as Stephen said, ours is not the only, but it's been a really interesting journey. So to start with what created the need, it's been a little bit of an evolution, because I would say pre-COVID, the need was really created from the fact that we had long wait lists and our capacity seemed limited. And so in looking for an opportunity to expand that capacity, we really started looking at what we at the time called virtual or hybrid cardiac rehab, which, those definitions have now changed. And what we did was to offer patients a 1-day-a-week program, but the other sessions were done asynchronously. So we did work with a mobile app, so we had patients set up with that. So the other days of the week, they were reporting their exercise data to us. There was a library of education included in that, so we could assign them education and so on. With the onset of COVID, like most, I'm sure, we were closed for 4 months. And so that need really shifted to how can we provide cardiac rehab to patients who initially couldn't come into our center at all. And then when we reopened, many were reluctant to come back to a facility-based program. So that need really shifted to how can we provide cardiac rehab in some way and be effective without using our facility-based program. And then now that we're back to pretty much full volume, we recognize that there's a need outside of patients being reluctant to come back based on, travel, other access issues such as work and that kind of thing. So our implementation process, we moved to implementing a full hybrid program. Just to run quickly through that, our patients are encouraged to come live for their initial consultation. So we do their physical assessments, their functional capacity assessment, review of their paper assessments. We do all of that live if at all possible. We also take that opportunity to set them up on their mobile app so they have that ready to go at home for any asynchronous reporting. And after that, they start their synchronized sessions from home. We worked with our IT department to use, they encouraged us to use an existing platform through our EMR. So there was a Zoom opportunity through that, so we used that for our platform. And then patients could link into the program, into their sessions through their patient portal. So they attend generally 2 days a week. Their synchronized sessions with us are 2 days a week. They link into the session. We do exercise during that session, and then after exercise, almost every time we do provide some live education as well. Every 30 days, we ask the patient to come back for a live monitored facility-based session to update their treatment plan and just to check in with them if at all possible. We also offer dietary consultation and smoking cessation consultation as separate Zoom sessions, so those are also done scheduled for the patient. So I guess lessons learned, it's quick, but lessons learned, what we found was that for group sessions, it's hard to do the exercise live and accommodate everyone's needs. We have some people that are very low level and some that are high level. So if they have exercise equipment at home, that works well. But if we're providing the exercise or we're playing a video, sometimes that's been challenging. It's also been more difficult than we thought to get patients to come back to a facility-based session. We try to schedule those up front so they have that on their calendar, but sometimes they get pretty comfortable with not coming into the facility. And then I think privacy issues are something else that we have to be really cognizant of discussing with the patient ahead of time, because there is some personal information that's exchanged via live audio visual, and so we want them to be aware of that. I think that's the time that I have, Stephen, so I'll toss it back to you.
Thanks very, very much, Ann, and that was a great summary. A couple editorial comments that just as I was listening to Ann, I wanted to comment on before digging back into the presentation. The first one is, we've been asking our patients to exercise at home for decades. And so what we're doing now is we're just going to try and give some shape to what we're already asking them to do. And for a lot of us, this creates problems or black boxes where we don't know where to go. And Ann said something that reminded me. It sounds like she picked up the phone and called her EMR people, her IT people, and they got involved to help solve how do we connect with the patients. And they were using it through their Zoom platform. Your IT departments, your care delivery, your virtual care delivery departments, especially because of the pandemic, are used to handling this now, and we can leverage that. We can leverage that to our advantage. We do about 1,500 to 2,000 of these virtual visits a year, and we got here because we just solved problems along the way. And you will too, in 2 or 3 years, get to about the same point. So that was my editorial comments. Back to the talk, and a little bit just about why cardiac rehabilitation and the benefits. So I want to move forward now as we start to talk about this information as we go on. First off, you can think of all the challenges and the barriers that patients have with respect to coming into a session, and with COVID, as Ann mentioned, coming into a facility with other exercising people was a concern. But these are also listed here are ones that you would think of that we would easily put 2 and 2 together and come up with. And the automatic referral and improved care coordination and handoffs from inpatient to outpatient will solve some of these, but not all of these. Next slide. So on the left, using diagrams again, on the left is a slide you've probably seen before at annual meetings. And the green heavy line, first outer circle, is patients that are never referred to cardiac rehabilitation. And the orange circle in the middle are the patients that are referred and start cardiac rehabilitation in a facility-based program. The red line are those patients right now in the US are few. They might be getting hybrid cardiac rehabilitation, and the blue line is they're referred, the blue circle is they're referred but never start. We want to get to the right. We want to make the circle in the middle bigger. We want more patients in a facility-based program. We want to shrink the green. We want more people enrolled, and that means the number, referred, that means the blue line gets bigger. The blue circle gets bigger, the number of people that are referred to cardiac rehabilitation. But in doing so, next slide, please. Go all the way over to the right. In doing so, we want to shrink that blue circle by also growing, not just facility-based, through better referrals and care coordination, et cetera, but also grow an alternate approach to attracting these people, and that could be, very easily be, hybrid cardiac rehabilitation. Next slide. So one of the questions we often got when we started to talk about our program with others is, well, how safe is it? And we're going to cover a couple safety issues here, and these are some just twists you might want to think about as you start your program or talk to others as they start their program. We try to get, don't always get, try to get a stress test on all of our patients before they begin, screening for ECG issues, blood pressure issues. But if we don't get that, we'll see the patients in some facility-based sessions, at least hopefully one, but maybe 3, 4, 5, or 6 before we let them go to synchronized audiovisual. So we're collecting a lot of that data through the normal monitoring that we would be doing in a facility-based program, rhythm, blood pressure issues, heart rate response, symptom management, et cetera. So we'll have that direct visual on them. And also we're going to still talk to patients while they're exercising at home. We'll get their heart rate response, we'll get their perceived exertion, and in some cases, patients will have blood pressure monitors and give us body weights, and we can do that both on and off site. So there's this, same type of surveillance or data managing or data following that we've had, whether it's in person or virtual or synchronized. And then we also do talk about the emergency plan with the patient. If there's a problem, what would be the plan that we'll follow? We do know we always ask the patient, what's your exercising site? And it's usually home, then we're okay. But if they're exercising at a hotel fitness center or exercising at work, we need to know that. And in some cases, we incorporate support people. So if it's a person that maybe needs a little bit more assistance for fall risk or communication, we may have a support person in the house as well. Next slide. So a couple other items about safety. I just want to emphasize there are no large randomized trials that have compared safety of hybrid cardiac rehabilitation to facility-based. They do not exist. Having said that, we do know, just by the nature of cardiac rehabilitation, that overall, the risk of having a problem in cardiac rehabilitation is very small for hospitalization, for a major event, or death. And that is a well-defined, well-understood, an event per, let's say, 500,000 patient hours or 100,000 to 500,000 patient hours. The data varies. But I will also share with you that among patients with stable heart failure, which these would be patients with class, C heart failure, NYHA class, 2 or 3 symptoms, the HF Action trial showed that after 3 months of cardiac rehabilitation, up to 1 year of home-based exercise in these people after finishing cardiac rehabilitation was not associated, and there was no supervision, was not associated with any increased risks compared to the control group. So I'm fairly comfortable saying that given good patient selection, given the status of the literature, we should feel fairly comfortable with exercising patients under good supervision with supervision at home. Next slide.
Actually, Stephen, let's jump in and just check with Ann on her experience with patient safety at Northwest Community.
Good catch. Go ahead.
Yeah, thank you. We've had, I mean, we have more limited experience than Stephen as far as our volumes of patients, but I can say that we've had no issues with safety either. We do risk stratify our patients prior to having them join the hybrid program. We do not get stress testing on everyone. However, we do risk stratify and do recommend facility-based cardiac rehab for those who are higher risk. I do agree with you though, Stephen, you have a lot of experience obviously with heart failure patients, but we have had some stable heart failure patients in our hybrid program as well, and they've done really well. Just sort of, you know, practical things, we are sure to get the patient location, phone number, emergency contact that we have, that the staff member has immediately available during the session. So if there is an issue, they know to call EMS to the right address. And then our physician supervision, we have our physician email and phone number, and we have the link to our session that we can send to the physician in the event that we need them to link into our session for any reason. So that's how we handle that physician supervision piece. And then I would just say, other than that, just really what Stephen already reviewed as far as, you know, regular check-ins with the patient. We talk with them throughout the session, ensuring that they are reporting any symptoms or any change in status. And then certainly reviewing with them RPE and heart rates and shortness of breath and that kind of thing. So far, we've had no issues with safety whatsoever.
Hey, thanks, Ann. I did want to comment and say there are 4 patient groups that we do not automatically don't start into our hybrid program. Those are patients with a left ventricular assist device. Those are patients who are on milrinone therapy or an inotrope. Those are patients that are on dialysis. We do not enroll them in the hybrid program. And patients that are symptomatic at 2 mets or less. So there are some patients that automatically we do take out of the consideration pool. In terms about effectiveness and moving forward with kind of outcomes or the modeling of hybrid, the modalities that we would use for exercise at home are quite similar to the modalities that you would use in your regular facility-based program. It could be walking. If a patient happens to be a hospital employee and they're walking in the basement hallways here at the hospital, and they might just be talking to us while they're on their cell phone because they've got good internet connection, through the hospital Wi-Fi. But it could be at home, it could be at fitness centers, it could be at community centers, and the same modalities that you see listed here. Next slide. We did generate a paper maybe a year or 2 ago. There is a stated concern that maybe patients exercise at home at a lower intensity than they do when they're supervised in rehab. And we generated a study out of one of our projects where we show that the intensity of training among people, and this is expressed as percent heart rate reserve, but the intensity of exercise training while patients are exercising at home was no different than the patients same patients are exercise training in a facility-based model. So the rigorousness or the intensity level was the same for both. And there have been several studies that have looked at the outcomes that we traditionally measure in cardiac rehabilitation, whether it's a hybrid model or a facility-based model, and things like quality of life, some risk factor management issues, and exercise capacity all seem to be similarly improved, not necessarily better, but certainly not worse than we would view in a facility-based program. And any comments from you relative to these same kind of effectiveness issues?
Yeah, I would say that our numbers are still small. So as far as comparative data, I don't think it's very reliable yet. So more anecdotally, I think it's just being cognizant of encouraging patients to do their exercise at their own level. We are operating in groups, small groups, and so It's important to encourage patients to do, to exercise at their level, whatever is appropriate for them. And if they have home exercise equipment, that's helpful because they can really titrate their exercise better that way. When we lead the exercises, we've vetted a bunch of videos, free videos, and we found some that have, higher levels, standing and, doing the exercises standing versus sitting, and we've used those and encourage patients to go at whatever level is most comfortable. So we've tried to address that in various ways. And then I would say outside exercise, the effectiveness of the program as far as encouraging risk factor modification, the education can be provided and the counseling for nutrition and smoking cessation and stress management. I mean, those are really easy to provide in a synchronous hybrid model. So yeah, I think the exercise probably for us has been the most challenging, but patients did, like I said, more anecdotally, but they certainly have improved.
Yeah, and thanks, Anna. I would just add that we've checked patient satisfaction, and the scores are off the chart. They really like the flexibility here, so that's just an observation. Next slide. So we're building demand, right? And there's our hope is to build even further. And there's a couple driving forces. We have an aging population, so not hopefully, but there will be more patients with qualifying events. And we're promoting this drive for demand, and hopefully we're getting there through better automatic referrals, and we're getting there through improved patient coordination and care coordination. And then the pandemic swings in, and there's just a whole host of other demand issues on cardiac rehabilitation. And it could be short staff. It could be I want to stay away from the hospital because of infection. And we have to spread patients out. So we lose the ability to have as many patients in the room. So these are all, and so to speak, driving demand to driving a need to be able to cope with cardiac rehabilitation in a different way. Next slide. So that's what I'm trying to show you here, is that, demand it can easily outstrip supply. And you've probably heard this commentary before, but if we fully loaded and tried to get into cardiac rehabilitation, all the patients that are eligible, or 70% of the patients that are eligible, we're trying to get them in, we'd far outstrip the capacity to handle it. Because if we ramped all programs to their full capability of existing programs, we'd only be able to handle 50% of demand. So we do need to look at these alternate delivery methods. In terms of some other things that hybrid cardiac rehabilitation might be able to help close or address, and it's some of these gaps in CR participation that we're aware of. And these are odds ratios or likelihood of participating in cardiac rehabilitation. You see those graphs going across the bottom of the screen. Non-whites are about 25% less likely to participate than white. Women are about 40% less likely to participate than men. Uninsured versus insured, a huge difference, and then educational level also. So there are some drivers here that potentially hybrid cardiac rehabilitation can help solve. Next slide. And there's not a lot of data around this, but it is worth mentioning, and that is the cost issues. And administrators, hospital finance people, they link into this. I understand that. And like cardiac rehabilitation, if brick and mortar, facility-based, we know it helps with hospitalizations, rehospitalizations, et cetera. So if we're broadening the people, broadening the critical mass of people that are exposed to cardiac rehabilitation by incorporating hybrid or getting more visits because of hybrid, then we're going to help in that way reduce hospital admissions as well. And in part of accountable care organizations, value-based plans, then this will be one way to help keep costs down. And because the operating costs for running cardiac rehabilitation are potentially lower in a hybrid model than in a full facility-based model. And there's some data to support that. Next slide. So an important concern, a rightly correct important concern for all of you that are probably asking the question is, how do we finance this? What's the reimbursement model for this? Well, we know all the on-site cardiac rehabilitation sessions that would be hybrid, in the hybrid model, would be reimbursed by traditional insurance companies. So we're not taking those away. If they come to your facility, then you would bill them as usual. The patients that are then doing synchronized, audiovisual connection remotely, currently during the public health emergency, as long as it is maintained, then Medicare will reimburse it and coverage it under that cover it under that paradigm. Now, whether that maintains going forward will depend on a lot of factors: future research, interest from those, derived from those that are currently doing it. But right now, it is a covered approach. I will tell you personally, Blue Cross Blue Shield in Michigan does cover it. I literally went to Blue Cross Blue Shield, made the presentation of what I wanted to cover, and before I even finished the presentation, they said, "Stop, we are going to do this." And working with your finance people to get an audience with Blue Cross in your state might be a reasonable thing for you to do. Medicare Advantage plans, private insurance, we have to continue to meet with these people, develop the data, demonstrate it. I know a couple hospitals that will say, we're not worried about the finances right now. You're a break-even program. Let's do this because it's the right thing to do. So others are working on this. We're working on this. We're advocating for this, but this will fall in line as we move forward. Next slide.
Yeah, and Stephen, before we move on, let me just acknowledge Karen Louie's input on those finance slides. We really appreciate her guidance on everything related to reimbursement issues for Medicare. So thanks very much, Karen. And then I also wanted to just check in and give Ann a chance to comment on how they've handled the reimbursement issues in their program.
Yeah, thank you, Stephen. I feel like in some ways we got started at just the right time when we were doing our what we were calling hybrid with asynchronous. Our thought was these are patients that we might lose otherwise. We were getting at least reimbursed for the facility-based sessions that the patients were coming to at that time, usually once a week. And they were doing, they were getting guidance for doing their home program and reporting to us through their mobile app. So that was our thinking at that time. And then when we moved to a full hybrid program, it was during COVID. So we have been getting reimbursed from Medicare patients. And also we're finding that most of the commercial payers are also following that right now. I am concerned for when or if Medicare decides that they will no longer cover this, potentially when the public health emergency ends. And I think what Stephen did in getting an audience with Blue Cross Blue Shield is exactly what we all need to be doing. I've only started my discussions with our finance department to say, what do we need to do in order to request that, we continue to be covered. I feel like I don't have enough data myself to present, but I can use that from the rest of you who have experience. So I really think that's the direction we need to go. I'm not sure our hospital will be as supportive in saying, let's continue this if it's a money losing proposition. But I think we can, we can figure out a model that will work to at least be break even.
Thanks. And then before we jump into this, I just want to note Wendy Johnson's comment in the chat. How do you evaluate a CVPR performance measure around the 40% MET level increase in an asynchronous program? Ann or Stephen, do you want to respond to that?
And you tackle first.
Yeah, so since we still are asking patients to come in at least once every 30 days, and that pretty much correlates with when we're updating their treatment plan, we would do a monitored session and we would have them use equipment at that time. So We also are doing a 6-minute walk test at the beginning and at the end. So we're evaluating it both with the peak METs for the first and the last session, and also with the 6-minute walk test.
And exactly, and I agree with Ann 100%. We have patients come back for those sessions, and we can gather data from them, whether it's quality of life, whether it's exercise capacity, you know, other dietary issues. We do exactly the same. We also have used, for some of the surveys, we've used email communication or delivering it by through their patient portal. And I quickly saw a comment about adherence. The data that's out there, adherence is no worse with a hybrid program. And there have been a couple of studies that have shown that adherence is better. And there are trials right now comparing head-to-head adherence in cardiac rehabilitation, hybrid versus facility-based. So next slide. So there's a couple key questions as we go down this journey that we want to ask ourselves about hybrid cardiac rehabilitation. I'm not going to cover the column to the right too much. You can read that and wrestle with that information at your leisure in your companion manuals. But let's just talk higher level. And the first off is, does your program have low enrollment rates? And I think everybody would say probably so. You know, we would like more MI patients, we'd like more revasc patients, but for sure heart failure patients, there's all areas that we'd like to improve upon. So the answer there would be a soft yes or a firm yes. Then ask your question, are you in or near CR desert? You know, do you reside in a place where eligible patients, it's just not feasible to access cardiac rehabilitation? A place might be the Upper Peninsula of Michigan, where the closest hospital might be, you know, an hour away, and it's unreasonable for patients to make that drive. So we're kind of setting the tone now for a place that hybrid might help us fill. Next slide. So do you have, you know, capacity issues? In terms of delay, Ann mentioned delays to get people in, or you know, just the volume of patients that are coming in the front door would be easier to handle them in another model. Hybrid might give you an opportunity to see an increased number of people in an alternate method without detracting too much from your staffing that would be in a traditional setting. And then, do you have strong financial incentives to avoid hospitalizations, readmissions? I think that the answer to that question would be yes for most of us. We'd like to think we plug into that part of the care continuum that many of us are on in the care of patients with cardiovascular disease. Next slide. So will payers reimburse? We talked about this for synchronized real-time sessions. It's fluid right now. People like Ann, myself, Karen Louie, we're looking at this. AACVPR is tuned into this. This is important. We don't want it to go away, but this will help. This interest moving forward will help drive things. And the question is, can you do it well, safe, high quality? We don't want to do this in a parcel fashion. We want to deliver all the components of cardiac rehabilitation. It provides social support, and these are the things we want to include as we go forward. And any quick comment there about any of those? Then we'll get on to some of this assessment.
No, I just you know, I particularly resonate with the last one. I guess I think, you know, doing it well is really important, and you highlighted at the beginning that, you know, what this isn't. And I think, you know, for anyone who's thinking about doing this, just ensuring that all the core components of cardiac rehab are included is really key.
So if you happen to use yes to most of those questions, then maybe exploring this opportunity of hybrid is something you should put on your radar screen. Slide. Next slide. So how do we induce this model for hybrid cardiac rehabilitation? And I would say thoughtfully, cautiously, let the data help guide you. There's many of us now that are willing to help others as you go down this journey. In the state of Michigan, we're talking about this actively, trying to help others in the state come up to hybrid cardiac rehabilitation. the pathways can exist and others are willing to help. Next slide. So the literature is out there. There's some references that we've mentioned. Those will be at the end of the presentation. We encourage you to look at that. There's a home-based cardiac rehabilitation. Randy Thomas is the first author, put out by ACC and HA, a good resource to look at there. And then, you know, you start to lay out the relevant groundwork. Who are your key stakeholders? Who are the decision makers? Who's your physician champion? Who's the administrator champion? Let them help appreciate, if possible, the importance of what you're trying to do. Get them to buy into it so they can start to speak on your behalf. And again, the timing is so appropriate because so much has swung to an audiovisual connection in healthcare. So they're thinking along that lines as they see care delivery. So lay the groundwork, start the conversations. Don't be bashful. This is what we need to do to speak on our behalf to do that. And then start to look at your own assessments. I mean, if you were to sit down and say, how do we put our arms around this? How do we give the shape? Who do we have to talk to? And you know, again, this might be IT or virtual care, your own staff. You know, can we do it at 2 o'clock in the afternoon? Can we do it at 5 o'clock in the afternoon? Can we do it at 7 o'clock in the morning? Can we do 1 class, 2? Start to give it shape and be more rigorous in your approach. And then assess your implementation options. And again, I alluded to that a little bit, but time of day, staffing matrices, days of the week. Maybe you're a Monday, Wednesday, Friday program, and Tuesday, Thursday would be good for you to go ahead and deliver this hybrid model. I do know for our staffing matrix, all of our exercise physiologists, not all of them, 6 of them, have a 2-hour block, 1 time a week where they cover the hybrid sessions. So they might have, let's say, you know, an hour and 15 minutes where they're connecting with patients by WebEx, and they've got part of that time to do their charting, part of that time to drop the bill, but there's allocated time for them to do it between about an hour or 2 each week. And somebody might cover the 2 o'clock class on Monday, somebody covers the Thursday at 4 o'clock class, and we've spread it out equally so it's not too burdensome on any one person. Next slide.
Yeah, and Stephen, there is a question in the chat about how many patients you monitor at a time synchronously.
Yeah, so and Anne needs to weigh in on this too, because it's a learning curve. We started off with 1-to-1, and then went to 1-to-2, and went to 1-to-3, and then we're up to 1-to-5 or 1-to-6 now, and it's a little bit of juggling, but you've got some good active groups that go as you go along. But it's a learning curve, and I will say the staff enjoys it. They like the interaction when you've got 3, 4, or 5 people on a call. And do you want to comment on that, because there's learning to be had here?
So we did the same. I mean, we set an arbitrary limit because it was new to us. We set an arbitrary limit of 6 in a session, in a group session, just thinking that was probably the number that one staff person could manage pretty well, with check-ins. And then also the documentation has been a learning curve for us. We don't use our monitoring system to enter data real time because it's just too many screens right now for them. So they're doing their documentation on paper, and then after the session, entering that into our monitoring system. So that's kind of a work in progress, but that's what we're doing now. So considering all of that, up to 6 was really the limit that we put in, and that seemed to work fine. We have varied from the low end of 1 to a full class of 6 during the time we've been operational.
And just in terms of a little bit of tidbit, I wanted to let you know that when the exercise session is going on, a hybrid, we do it in what we call our bat cave. It's a room where the staff meets, you know, has the screens in front of them, and they do it. But if there's a problem that's happening, if there's a patient that's having a problem with video connecting, then we will text the backup person. And for every class, there's a backup person, and that person will work with the patient so it doesn't disrupt the whole class. On the one time that we had a patient problem, and I think it might have been a fall related, we've had 1 fall or 2 falls total, we felt it was appropriate that we just said the session's canceled today, and so that we could work with just that patient. And everybody understood. But we had a backup person that was willing to always step in and help a patient that had a clinical problem that was non-emergent or a video connect issue. So how would we look going forward in terms of implementation? You could create your own program if you feel like this is something you can do. You've got the bandwidth, you've got the size. You could partnership technically with another program. And I'll let you see the advantages and disadvantages as they're there. But maybe you're at a larger hospital and you can help other hospitals and take their patients for the hybrid sessions, and the patients would go back to the referring center for the in-facility visits. You could develop some kind of partnership. And if you're the small hospital, in Michigan, then maybe you would work with, the Spectrum or the U of M or the Henry Ford, because they're offering hybrid for the virtual connections. Or there are vendor platforms that are out there. You can see how those articulate with you. So there are some options to go ahead and consider. Next slide. So moving forward on next steps, you want to collect data, relevant data, and whether that's number of visits, whether that's patient satisfaction, whether that's things that we're traditionally capturing in terms of functional improvement or quality of life. It could be operational efficiency. We have a staff person who is not part of the session once every couple of months, sit in on at least one other staff person to view how the session is going and provide feedback in terms of quality delivery. So if Ann's the staff person that's running the session, I may sit in the back of the room and kind of audit her, and we'll talk about things later. And it's not a critical approach, it's a learning curve. So there's ways you can do it to make sure high quality care is being delivered throughout. Keep the patient in the first of everything we do, and I come back to say, deliver all the key components of cardiac rehabilitation, and then get advice from people around you that are further ahead on the curve. And our group, there's, Alexis Beatty's group, I know Kate Trainer's delivered at Mass General. There's other programs that are out there, and I would encourage that as well. Next slide.
And perhaps before we move into these questions, we'll just check in for, a last piece of advice or two from Ann to add on to the very useful suggestions that Stephen just made.
Yeah, I think, if I have any piece of advice, it's really just to, I feel like it's been a great addition to our repertoire of program offerings. And I would just encourage you to, go through the 6 questions that Stephen offered in this presentation. And if it seems like something that would work for your facility, to go ahead and at least explore how it could be done. Checking in from our perspective in the hospital, it was checking in with IT. They were extremely helpful in helping us with creating the platform. Certainly with patient financial services, the way that we bill now, it had to be set up, the patient's home had to be set up as a site of service. So they knew exactly what to do. As Stephen said, they're used to doing like virtual services now. So they knew exactly what I was talking about. Also, checking in frequently with our medical director and with the cardiology group. They were fine with it. They had some questions though, so I think it's really important to keep them in the loop as the program is developed. And I think you'll find that your team is interested in creating something like this too. I guess from a precautionary side, the main thing that bubbles up to me always is the financial piece. And I think we'll just all be watching really carefully to see where that goes from the Medicare perspective. But then also, as I mentioned and Stephen mentioned earlier, to be proactive in approaching some of the commercial payers to see if they're willing to consider payment.
And just a final comment to me, and I think I may have mentioned this already. But for a lot of us, this is a black box. We just don't know what's underneath, and we're smart people. We can solve problems. So I would encourage you just to start to peel off the layers of the box until you get to where you want to go. It may take you 6 months, 8 months. It might have taken us 10 months to ramp this thing up. But we can do this in a judicious and quality manner. And I would encourage you to think about it or connect with others to help you along. So Steve, I can stop there and we can go to the chat. I'm not quite sure what format we were going to follow, but we can certainly entertain if there's questions.
Yeah, thanks very much, Stephen and Ann, for great insights and for covering an incredible amount of material very quickly. We do want to encourage all of you to share with us an insight, you know, the one thing that you're going to take away from this that was you found a really useful idea, a valuable insight. So enter those in the chat, and then we've been trying to answer questions as we've gone along. But if you have other questions, we've got a couple minutes to answer them. So by all means, put those in as well. There's a question from Julia Vinsky about the use of the mobile, which mobile app is used. You know, obviously we don't endorse any specific, you know, apps or platforms or whatever. But I'm sure that others that may be using mobile apps can respond to that question in the chat. But if there are other questions, by all means, put those into the chat. And I do think that one of the exciting things about this is that everybody's program, you know, if you do set up a hybrid option, yours may not look exactly the same ways that Stevens does or that Ann's does. You know, if many of your patients that are coming from remote, just a long way away, then they may be able to come in, you know, less often than is the case for Ann's program. So there's not one right way to do hybrid. It's just what's going to be right for you and for your patients.
So just two questions I wanted to pull out of the chat box. The first one is, can you do this while running an in-person session as well? I've never seen that. That would be something to test. I have not seen that, and my mind's racing a little bit. That's a really intuitive question. And the other question is, what is reimbursement you receive? The disconnect between bill and reimbursement is like, they go past each other with me sometimes. So I will say that at least in the state of Michigan, reimbursement, if you're delivering the same service, is supposed to be the same. Getting it correctly, we had to work closely with our billing people, but reimbursement level is okay here. So that if it's a reimbursed service, that's not a deterrent in terms of a dollar amount. Once we got all the electrons to talk correctly in terms of modifiers and whatnot.
Thanks. And one last question that was in the chat that maybe you could both comment on frequently, and that is, how do you help patients that are struggling with the technical aspects? And I think, Stephen, you said that, you know, you may help have somebody help, you know, behind the scenes. But Ann, is that an issue for you? And if so, how do you support patients that might be struggling with that?
Yeah, it's a great question. I would say for the most part, the patients so far who have opted for this have had some expertise, or probably not expertise, but at least we're comfortable with the level of technology that they needed to be. When they come in live for their initial consultation session, we do go through that with them. So we try to use that as kind of a learning session, both to teach them the mobile app and also to teach them how they'll link into the session. If they have the patient portal already, it makes it pretty easy because they get a message and all they have to do is click on that link. But having said that, we have had some technology issues. In most cases, there was someone at home that could help that individual. But I do like your idea of having a backup person that could kind of link in and help with that. We haven't had a lot of issues, but that would be useful.
All right, thanks very much again to Ann and Stephen for great insights, and to all of you in the audience for your comments and questions. All of the resources and the links to the slides will be sent out to you in the next couple of days. You can see those on the next couple of slides here. We have them all included. And then just as a reminder, a lot of the details and even more details than were covered in the slides are going to be included in the implementation guide that will also be circulating to everyone that's on this call, whether or not you're actually one of the participating Take Heart hospitals. And those are all on the website as well. As a reminder for our partner hospitals, the peer action groups coming up will give you a chance to discuss this, ask questions in a small group setting so that we can help you along the way. So, and if you have questions, by all means, contact your coaches and they will be happy to support you. We would like you to respond to these last feedback questions at the end before you wrap up this afternoon. We recognize your time is very valuable, and we thank you for investing an hour of it this afternoon. Thanks again to Stephen and Ann for their incredible insights, and we hope you all have an excellent rest of your day.